Hi, hope can you hear me? Yes, I think everything is working fine now. Hello everyone. I'm Pere, I'm a pediatric immunologist working in Vall Hospital in Barcelona, Catalonia, Spain, and I'm honored to be chairing this webinar on AI for primary immune deficiencies. I have to say that being part of this Jeffrey Model Foundation webinars is exciting to me, and I mean it's incredible to be honest to be here. So thank you very much for joining. To all of you, it's wonderful to know that we have more than sorry, I cannot see the slides. Things going wrong. Accepted. Roger, can you help me with that? I cannot see the slides. So I was just going to say that we are more than 300 attendees from 52 countries from all the continents in the world. And it's 4th of August, so it's amazing. We are actually, thank you very much, Nick. So we are actually a very committed community, and it's amazing to be here. So we'll have two speakers today. Will be Nick Ryder and also Jacques Riviere. They will give their talks, and we will have the questions at the end. So feel free to text your questions to the chat or the Q&A section. I'll be monitoring them together with the colleagues from the Jeffrey Model Foundation, and we will try to select them because I don't think we'll have time for all of them at the end. So I will address them to the speakers. So here you know that I'm not the important one. We have two wonderful speakers. The first one will be Dr. Nick Ryder. He's currently serving as a professional in the Department of Health Systems and Implementation Science at the Virginia Tech Carilion School of Medicine in Roanoke, Virginia. He runs Chile, the Computational Human Immunology Lab and Innovation Hub. And as you may know, he's a director of the first Jeffrey Model Foundation Center for Informatics and Data Science at Virginia Tech, which is it's an amazing recognition. Congrats, Nick, for that. And the second one will be Jacques Riviere. Jacques Riviere is a pediatric immunologist working at my center here at Vall Hospital in Barcelona, which is a Jeffrey Model Diagnostic and Research Center for Primary Immune Deficiencies. And in addition of his clinical practice, he's currently serving as the head of clinical informatics at the hospital. You may know that he's leading the PITCAP project, which is a research project that aims to improve the early detection of at the primary care level. So if you go to the next slide, Nick, please. Yes, this will be the learning objectives. I would just shortly describe them. We will try to describe the current diagnostic challenges in the diagnosis of primary immune deficiencies. We will try to see how AI and clinical informatics tools can support early identification of those patients, trying to recognize the importance of combining both clinical expertise and data-driven approaches, and try to discuss the challenges for the implementation of AI in PI, and also to identify future opportunities. I'm sure that these topics will all be covered by the two speakers, but if you have any questions, as I said before, just write it down on the chat and I'll pick them all. Okay, next slide. Probably the reason why I'm here is that in 2022 in Gothenburg in an ESIT meeting together with Manish Butte, we started thinking about the possibility of having a kind of AI meeting for primary immune deficiencies. And then we tried to organize it all. And we started in 2023 in Barcelona with this first IPIT meeting with a D that it's now missing. And it was amazing. It has a lot of brilliant people out there. To be honest, I learned a lot. But then I decided that I needed to step aside, but because there were guys that knew much more than me on that. And that's why at that point, Manish stood there, but probably Jacques and Nick started moving it all. And as you can see, Vanessa was there in the picture. And the reason for that is that Jeffrey Model Foundation has helped us a lot since the very beginning. And the good thing is that it's not only 2023 and 25, but also we will have this 2027 third meeting in Barcelona. As soon as we get the dates, we will share it with you. But please set the date because we will be more than happy to have you there. So next. And as I said before, this would have not been possible without the Jeffrey Model Foundation. I mean, it's wonderful to have Fred, to have Vanessa always there, but also all these guys, Roger, you have Jessica, who are helping us with the webinar, and obviously they're helping us to make anything that we want. I mean, they are building a real community since the very beginning, and it's wonderful to have you there. Thank you very much. So next slide. And the reason why we start thinking about that is that more than 5 years ago, we already knew that the diagnosis of primary immune deficiencies, or inborn errors of immunity, as we now call them, it was complex. It was complex from a clinical perspective, also from a genetic perspective, from immunological perspective. Everything was complex. We have more patients, adult patients with different phenotypes, genotypes, and so on. And the good thing is that we knew that we have all the information, but this information was siloed, and we could not use that. And that led to a significant diagnostic delay that it's around 4 to 7 years for most patients, but can be even for decades. And that leads to organ damage, even when those patients are diagnosed for the first time, and that leads to long-term sequelae. And obviously that's not acceptable. So in the old times, we tried those patients not to die. And I think that we have done a lot on that, but we need to improve our patients' quality of life. So earlier diagnosis is key, as you can see, for newborn screening for SCID and other diseases. So that's why we still need to work on that. So next. So even though we have tried to work a lot in these 5 years, still some questions remain. We do a lot of awareness activities, but are they alone enough to promote this early diagnosis? I think they're not, but I'd love to hear from Jacques and Nick. We need to decide how, as a community, and I think that's key, we need to tackle this diagnostic delay, and then how we can implement potential solutions. And you will see that we will talking about implementation science a lot during this talk, because it's not having the ideas. Most of us can have brilliant ideas, but they need to be implemented to be a real benefit for our patients and their families. So having said that, once again, thank you very much for being here. And now it's time for Dr. Raida to start speaking. So Nick, the floor is yours. Thank you very much.
Thank you, Pere. It's such a pleasure to be here with you all. Very grateful to be part of this awesome webinar and share the stage with both Pere and Jacques. Thank you to all, everyone who's here for your time, and to the Jeffrey Modell Foundation, of course, for sponsoring this. So just for a few slides, I want to tell you something you already know, but I want to drive home the impact of this. And this is some work done by a really terrific graduate student, Roxana Farzad, in my lab, who is just really calling out the journey to a primary immune disease diagnosis for a patient. So this is data extracted from real-world EHR data that's de-identified for a single CVID patient. And what you can see is, if you look across the span of about 33 years, this individual from first symptom onset to diagnosis underwent 64 therapeutic interventions, 92 laboratory investigations, 46 procedures, and 115 diagnoses and visits were given. So this is a stark reminder of what we see in the clinic, what we hear in the clinic every day, and that is patients have a long and protracted diagnostic odyssey that's often very painful, very uncomfortable, very stressful. And so AI for PI was started by a community, and we're going to talk about many of the important people who have contributed to this, of individuals led by the Jeffrey Modell Foundation, of course, to really seek to compress this journey and this odyssey. And so if we look at some additional work that Roxana has put together from the same nationally representative data set, here looking not at the individual level, but the cohort level, if we look at both CVID patients by sex, male on top, female on the bottom graph, and we look at accumulation of diagnoses over time, and these are by ICD chapter, International Classification of Disease chapter, you see that males have somewhat of a bimodal accumulation, whereas females have a more of a unimodal accumulating diagnoses over time. And just to drill into this a little bit, some of the predominant areas of pathology that are encoded by clinicians in the real world, seeing these patients and caring for them: cardiovascular disease, gastrointestinal disease, pulmonary disease, and just general healthcare utilization are accumulated at a rapid rate for these patients. So what this tells us is there's really a signal in the EHR, in claims data, that we can use and leverage to find these patients and bring them to medical attention earlier. The second point I want to make is that As members of this community, and I think there are 300 plus strong of us in this webinar, which is just amazing. Um, but as many of us, all of us know, even though we consider primary immune disease a rare disease, which in the United States is defined as 200,000 or less individuals, collectively, this is not terribly rare. We did mine Optum data a few years ago where we tried to estimate the prevalence of primary immune disease. And from that study, we estimated 60 per 100,000 individuals have primary immune disease in the United States. And what does that roll up to? If we looked at the US population from just a few months back, about 348 million individuals, that means that there are roughly 200,000 or maybe a little bit more patients with primary immune disease who have a very robust clinical phenotype sufficient to catalog them from structured EHR data. So undoubtedly, this is the tip of the iceberg. At least 50% of these individuals are undiagnosed. So this number may be doubled. If we look at other countries and regions of the world, in this case, Latin America, looking at the total population of Latin America at over 600 million individuals from several months ago, the estimated Latin American primary immune disease population would total about 400,000 individuals. So we know that there are many patients out there who are undiagnosed. We know that there are many patients out there in general, and the world population estimate for primary immune disease is roughly 5 million individuals. So given all of that, and given the patient burden collectively and individually, and the expected prevalence of primary immune disease, the question that we've really focused on as a community and in our group is how do we systematically shorten the diagnostic lag? Diagnostic lag being a little bit different from diagnostic odyssey. Odyssey really the story of the accumulated comorbidities over time. The diagnostic lag is really the time from the first attributable primary immune disease symptom to the time that the individual gets a specific diagnosis. And we've sought to tackle this in a few ways. One, through population level risk stratification. Second, through deploying validated web-based tools that would be available to anyone with access to the internet. And then for strategies that focus on scaling knowledge and systems, because we want this to be generalizably useful and accessible. So I'll step through some high-level data on each of these. So talking about population risk stratification first and foremost, as many of you know, we have leveraged the software for primary immune deficiency recognition, intervention, and tracking, or the Spirit Analyzer from the Jeffrey Modell Foundation. And this tool is very useful in functioning as a population stratification tool and taking any population of individuals, identifying a high-risk group, and then using other computational tools such as natural language processing or NLP, other machine learning algorithms to identify those individuals who are most amenable to referral to an expert clinical immunologist. And through our work, we've been able to show that prevalence in the general population of 60 per 100,000 individuals can be concentrated 200-fold to about 12,000 per 100,000 individuals. And ultimately, we expect, and we look forward to validating this further, but we expect that we can expedite the diagnosis using the Spirit Analyzer and other tools by at least 3 years. So looking at one study that we published from a few years back, this was done at a single center, Texas Children's Hospital, when I was there. This is showing you the arc of time, which is about 3 years in the blue horizontal arrow shown at the bottom. And then each yellow arrow represents 12 months of claims data that was pulled at 6-month intervals with a number of assessments over time. And the goal here was to use the Spirit Analyzer at 6-month intervals, identify high-risk populations, and then use human insight, domain expertise to identify those individuals who are most amenable to referral to an expert clinical immunologist. This is just showing you a little bit more of our workflow, starting from left to right with the general population, using step one, the Spirit Analyzer, to identify those individuals who are high risk, those who are low or medium risk or of no appreciable claims risk, would be recycled back into the population to be reanalyzed over time, understanding that risk does accrue over time. And so an individual with no or low risk may develop appreciable risk over time. For those individuals that are high risk, we pass their information onto a second machine learning classifier in this case, and then we compare the output of that blinded model to humans who know who actually should be referred and not. And so those individuals who are risk stratified by the second step are assessed by both the model and humans to identify which should be worked up and referred, or who should be evaluated further over time. And ultimately, this was looking at about 427,000 individuals over this 3-year arc of time. 490 individuals were deemed potential primary immune disease patients. 37 were identified for referral to expert clinical immunologists. This is how risk category outcomes over 30 months. So what I'm showing you here on the left side is the size of the population, high, low to medium risk, and no claim of interest. And so you can see the vast majority of individuals were no claim of interest, with only 297 individuals that were deemed high risk via the Spirit analyzer. But if we look back over 30 months, the number or the proportion of individuals with a new PI diagnosis and the hospitalization rate per capita were statistically significantly enriched among the high risk population as deemed by Spirit. Urgent care visits per capita didn't quite meet statistical significance, but we expect that they might with other studies and over a longer period of time. So just to dive in a little bit more on the Spirit Analyzer, historically, this tool has been very effective in using claims data, ingesting that, looking at pre-specified, pre-weighted structured data elements, and then ascertaining a risk level for each individual member of the population as shared. What we're moving on to really this year, and we expect to have this available by the end of 2026, is a revitalized tool, the Spirit Analyzer 4.0, that can ingest not only claims data, but electronic health record data, structured data, provide a risk level, but also provide cytopenia flags and flags that are relevant to structured laboratory data. We also expect to be able to do a calculated globulin on every individual of the population who has sufficient chemistry data to calculate that. So in this way, Spirit can be multifunctional and analyze either EHR data or claims data. The other point I want to make about the Spirit Analyzer is that we've enhanced the features over time. As a community, we've recognized that immune dysregulation and primary immune regulatory disorders have increased, and many across this community have identified novel mechanisms of disease and characterized these patients. And the original code set for the Spirit Analyzer didn't have these as features because we simply didn't know about the pathobiology of primary immune disease at the time. But over time, we've baked these codes and curated them into the Spirit Analyzer. And what you can see in the upper panel are warning signs that are enriched among a primary immune disease cohort versus a general control cohort. Again, this was from the Optum study as previously referenced. But I just want to call out that these immune dysregulation relevant codes, such as bronchiectasis, lymphadenopathy, organomegaly, very early onset inflammatory bowel disease, and so forth, have made their way into the Spirit Analyzer and will be part of the upgrade that will be available later this year. So just to underscore the fact, the warning signs are indeed effective flags for primary immune disease identification. They're a good tool for identifying those individuals who are at risk. And while the diagnostic codes in the Spirit Analyzer roll up to the warning signs, the Spirit Analyzer itself doesn't necessarily analyze only on warning signs, but it does report warning signs. So what we wanted to show here was the proportion of individuals who had known primary immune disease and having 2 or more warning signs compared to a general control population. And you can see in the lower left, the accumulation of warning signs over time in orange in the pediatric population up to the age of 17, and in blue, the adult population. And we can see that there's an order of magnitude increase in the proportion of individuals who have 2 or more warning signs in the primary immune disease cohort. So all of that data really focused on, or all that work really focused on structured EHR or claims data. I want to just speak a moment about unstructured data because certainly there's tremendous signal and clinical notes. And while this is messy data, it can often be harnessed to identify patients and used as a fine-grained tool on the back end of Spirit or other tools. This was work that was co-led by Dr. Kirk Roberts of the University of Texas McWilliams School of Biomedical Informatics. Dr. Roberts and I conducted this study using clinical notes from a single center. As you can see here, these individuals enumerated about 5,900 cases with primary immune disease versus 28,000 controls. We subsetted the primary immune disease population into pre-diagnosis notes and post-diagnosis notes, and then trained a support vector machine NLP classifier on the pre-diagnosis alone. So we were really analyzing the language that healthcare professionals use in describing patients with PI before they were ever given a diagnosis. And that was how the model was trained. If we just look at some of the features of the notes and the enriched terms across the primary immune disease notes, these are often very noisy, and there's over 120,000 that were enriched and unique amongst the PI notes versus the controls. But there were over 300 domain relevant terms and concepts that numbered 16. So concepts such as opportunistic infections or immune dysregulation, terms such as lymphadenopathy or pneumocystis jirovecii pneumonia, for example. And ultimately, what we showed with this study in a single pilot study is that we could give the model that was trained on pre-diagnosis notes all of the information up to the time of the diagnosis the clinician made for these patients, and it was area under the precision recall curve was almost 100%, 97%. How about if we give all of the notes up to 6 months out from diagnosis, 12 months out, 18 months, and even 36 months out from diagnosis? The classifier remained robust with its performance and was able to still ascertain individuals who and identify individuals who had primary immune disease versus controls. So moving from population level risk stratification to really supporting clinicians anywhere, could we leverage current either open source or OpenAI LLMs, and this was done just a year or so ago? Could we use such tools to provide expert clinical immunology expertise and guidance to individuals who would maybe access a model like this across the web? And as you can see, a number of highly recognized clinical immunologists and computational experts. This was co-led by Ying-Ye Li of Boston Children's. And what we did is each clinical immunologist brought 5 real-world primary immune disease cases from across the IUIS spectrum. These were de-identified, and each immunologist interacted with, so as a team, we interacted with the LLMs in a chain of thought prompting fashion to ask the LLM as a primary care professional might about these cases and trying to arrive at a diagnosis. And so we measured 2 things here, and you can see the 6 models that we used. And we measured both mean accuracy, whether the LLM could get the diagnosis right, or whether that diagnosis was part of a differential diagnosis that was relevant to that case. And secondarily, we also asked how succinct and useful the information that the LLM provided was. You can see that the mean accuracy across all 6 models was 72.4%, but there were 3 high flyers that had an accuracy of above 88%. We also used something called the R-IDEA score to quantify the utility and the succinctness of the recommendations by the model, and the 3 high flyers also had significantly better R-IDEA scores. So this encouraged us that future work could certainly be undertaken to tune LLMs, deploy them across the web, and provide expert diagnostic guidance for clinicians around the world who may be experiencing evaluations for patients with primary immune disease. And then lastly, facilitating AI adoption. Again, we want to scale knowledge. We don't want AI of any shape or form for patients with primary immune disease discovery to be siloed in certain institutions. We want this to be available worldwide. So we developed Project Echo for primary immune disease, or PEPI, and this is a collaboration with colleagues that you'll recognize, Monica Lawrence and Larry Borish of the University of Virginia. In addition, Angie Tyria, a nurse in Lynchburg, Virginia, and a graduate student in my lab, Jacob Blakovich. And our goal in creating Project Echo for primary immune disease was really threefold. We wanted to provide expert elbow support to clinicians across rural Appalachia and rural America who may be encountering patients with primary immune disease and be uncertain about how to work them up and potentially refer them. So we wanted to provide that free elbow support. Additionally, we wanted to provide webinars and educational offerings, both as a CME 1-hour sessions as well as lunchtime sessions that were bite-sized that could fit into primary care professionals' busy schedules. And then lastly, we really wanted to ultimately, and this is yet to be done, to provide analytics consultation to help deploy, stand up, and implement our AI pipeline. So again, it can be generalizably useful. So I want to make sure that I'm really respectful for the incredible efforts that this community has had across the Americas. And Jacques will talk about the European experience, but I'm grateful to be speaking in this webinar, but certainly I am not the only one, nor is my team the only one in the Americas that is focusing on this work. We're great to have great collaborators across UCLA with Manish Butte, CHOP, Children's Hospital of Philadelphia with Kathleen Sullivan, Dr. Saul Lugo Reyes at Mexico City, and others who are doing work in this space. And so as our community AIPI grows, we'll continue to see more and more groups contributing to this, and that's essential because it certainly takes a village to improve outcomes for these patients. I'll just give a shout out at this point. You'll see me again, but so many people have been involved in our work, and I just want to briefly recognize them and thank them. And so from here, we'll move from warning signs to implementation, and I'll turn the mic over to my dear colleague, Jacques Riviere. Dr. Riviere, please take it away.
Thank you, Nick. Thank you. So it's really an honor for me to be here today. As Nick and Pere introduced already the subject, and we can go to the next slide, Nick, please. Really, the problem that we have with PI, we know it. We've been knowing it for a long time now, and we still are looking for the best window of opportunity between, let's say, birth and irreversible sequelae, where we can detect and try to detect earlier PI, because there is a lot of missed opportunity, and that cannot be the way we do things. So we really have to go there and try to have those windows of opportunity. Next slide. So as a community, we have a lot of things that have been going in the last, let's say, decades on going and narrow this the diagnostic lag as Nick presented. In fact, Nick has done a lot of work on assessing this diagnostic lag in the US. But we know that what really works and is nowadays in a lot of countries in newborn screening, then how there is a lot of other initiatives that have shown some promising results, let's say, but are not massively put it in the daily clinics, let's say. So today I'm gonna concentrate on PIT-CAP. SPIRIT was explained by Dr. Ryder, along with a bit with calculated globulin that we also use time to time. There is a lot of initiative, as we say, and if we can pass to the next slide. And that have been published. Nick presented the North American, let's say, or the North American efforts before, and I wanted to emphasize also on the European efforts, because as Dr. Ryder said, it takes a village. So it's a small community who are working in that part of our already small community field, but there is a lot of people involved. With different initiatives, or sometimes similar and sometimes different approaches. I've put a few examples of them. It's of course not everybody who has published or done work is represented on that slide, but just as example, there is initiative with more primary care data based features, which is, for example, the work of the group of Helen Levis in the Netherlands, which is the second article, Misselink et al., that was published. First the description, then the validation, which has the goal to focus on production antibody deficiency in primary care, but there is also the use of, let's say, registry or no, more strategic data as a good tool to use with AI to help the diagnostic effort for patient with PI, which was done with the acid registry, and also few initiative on the use of genomic and the use of flow cytometry also was being published by the Belgium group. So in general, there is, let's say, a whole different initiative from, let's say, primary care to tertiary care on using AI or ML to expedite a diagnosis of PI. One of those is the work that we've done with PITCAP, and that I will present part of it after. Next slide, please. So this is last year we published a bit a review on the current perspective of challenging of AI in PI. There was some of the publication that Nick commented, and I commented also, and there is more that have been published since then. Next. So regarding the PITCAP project, the PITCAP project has been around now for almost a decade. It started in Barcelona, in our area, and it was really inspired by the JMF. In fact, we had already 10 years ago some speaking with the JMF about this project and how to use the warning signs to leverage the warning signs and to apply them in our community. So the goal is to identify high risk patient with PI in the Catalan health system, and it's based on ICD code. Maybe the distinctiveness of this project is that comparing to maybe other projects, besides immunologists, there was a big role of primary care physician, general pediatrician, and also adult general physician that were already implicated at the very beginning of the project, and that helped us really to modulate all the data and all the model that we had from the beginning. Next slide. So what we've done first in that project is that we started in 1993 with a review of literature from 1993 to onward, because it was when the 10 JMF warning signs were published, and we did a literature review where we really flagged all the warning signs that all of you already know that have been around in the last decades, beside infectious disease, beside other already known warning sign, and that arise from the literature and our experience. Then we ask expert consensus through a Delphi methodology in Catalonia and Spain, which is a relatively small country, but with people dedicated to IEI, and then we adapt those warning signs to ICD coding to map all the warning signs to ICD code. Next slide. So basically, with that, we end up with 24 pediatric warning signs from the 10 JMF original, and also 24 adult warning signs. Sorry, there's a typo. It's 27 pediatric warning signs and 24 adult warning signs. With a lot of ICD code map. That was an important job to try to map the exact code for each warning sign. And this also, maybe the difference with other project is that the same warning sign didn't have the same weight in that project. For example, having 3 pneumonias could have a certain weight, which was higher than having eczema, for example, or chronic eczema or other PI manifestation that when we think about how we usually do our clinical work as it's an expert-based algorithm. We try to reflect that with the opinion of the experts, saying when you think about a possible PI diagnosis, which has more weight? Is it, let's say, the severe sepsis or the recurrent otitis, and how we weight those clinical features? So with that, we had a scoring, and if the patient went above a certain threshold, and we can go to the next line, Nick. This would trigger an alert embedded into the primary care physician EHR system, where he or she could ask for an homological workup if it wasn't already done, and had two choices if it wasn't already diagnosed or explained by another reason, which are a virtual referral to the reference center, or directly a physical an in-person referral to their reference center. Next slide. So with that model, we did a pilot real life in primary care population around our area in Barcelona. Around 20,000 people are taken care of in that particular center of primary care. And what we really wanted to assess and fine tune here wasn't the sensitivity of the algorithm, but the realistic possibility of embedding it into the clinical the daily clinical practice pipeline, where there is not a lot of time for GPs or for general pediatrician, and there is a lot of work. So the idea was to have something clinically manageable with a low, as low as it can be alert rate, but still flag patient with PI. Maybe not all of them, but at least flag some of them. So we managed to have a 1.5% of alert rate, which was clinically accepted by the GPs. It was 0.5 in pediatrics and 1.7 in adults. Next slide. In parallel, the balance was to achieve that percentage of clinically manageable rate alert. We had to sacrifice, let's say, some sensitivity. So the algorithm was able to detect around 30% of patients were already diagnosed with an II with only the ICD codes in primary care before diagnosis. There was this work was published almost 2 years ago. Next slide, please. So after that, we wanted to try to increase the community, and increase the village, as Nick said before. So we wanted to because there is different, as we said before, as Nick said, and as I presented at the beginning of my talk, there is a lot of different initiatives, but it's hard to implement. So we really wanted to have a consensus that was not only for Catalonia and Spain, but also for other countries. So in collaboration with the CIS, ESID, INGID, and IPOPI, under the umbrella of the JMF, we asked we did a Delphi for an updating warning signs with more than 100 experts, included physician, nurses, and patient. Can you pass the next slide? So we did that in Europe and North America last year. This is about to be it's about to be submitted really soon. And in parallel, we also started in Latin America. We wanted to do a special focus in Latin America, as that might be pathogens sometimes or a bit different, and we decided to do it sequentially, but maybe the result will be very similar or similar. So with that, we'll have more conclusion. Next slide. On the North American Europe point of view, we had more than 100 experts from 22 different countries with a really high participation rate, around 95% almost. And I'm going to show you what we ask in the next slide. So we basically asked point by point on the different warning signs, both pediatric and adults, if this warning sign was considered for them with the Likert scale as something to be considered for a PI diagnostic differential diagnosis, and what was the score of it in the first round, and then in the second round we reward or clarify the sign. Next slide. So from those 22 countries, more or less, we had 60-40 proportion between Europe and US and Canada, with the majority of the respondent were physician, but also nurse and patients. Next. On the 27 warning signs assessed in the pediatric warning signs that we took from the Spanish and Catalan consensus, we achieved a final consensus of 26 of 27 warning signs. 9 were sufficient for direct referral, which means that the presence of the experts thought that the presence of those warning signs were good enough to trigger directly a referral to an immunologist, whereas 17 were considered to not be sufficient alone, but to need other warning signs to add up to the puzzle. In the adult warning signs no problem, Nick. In the adult warning signs from the 24 that we assessed, we got a final consensus on 17, which is a bit less, but still with a lot of consensus, and 4 were direct referral, and 13 on not sufficient alone. Next slide. So those are the warning signs from the Delphi consensus, and truly it's something that we did with the JMF and wanting to give back to the JMF also, and of course in memoriam of Vicky, and the let's say the 10 warning signs with an update of those warning signs by the whole community. There is a lot of participants, expert figures in the field that have participated in this consensus, and we wanted to thank you for the generosity of the GMF of that. Next slide. So PIT capacity is limitation. It's based on ICD code. This version of PIT cap, it can differ geographically, and there is things that don't take into account if there is a patient with an MRSA or other thing. This has been done in collaboration with a research group called DS3 here in Catalonia, and that really helped us understanding, and it was also presented in the meeting in the IPI in New York in the last meeting, that the implementation is key. It's not only to have a good algorithm, but also it's to be able to implement it. And we can go to the next slide. And this is, I think, the biggest challenge that we have now in our community, more than looking for the way to screen patient. There is a lot of different way. I think a lot of them are really good. So it's not that it doesn't matter the way you do it, but it's really important how you apply it and how you scale up and you integrate it. And the implementation science is really key for that. And with that, I would like to end my presentation and acknowledge a lot of people who have done this work possible. In fact, I I had on previous slide, I have all the Delphi participant, but now they don't fit in there. So I had to put just the all Delphi participant. But there is really a lot of people that have been part of the journey, and of course all of the patient and families who inspire us to do our job, and that's what we do that for them. So thanks a lot. And now Nick is going to speak on implementation a bit, on what is next, and how we want to do it. Nick, go ahead.
Thanks, Jacques. This is great. So actually, let me just step back a slide here. So as you heard, lots of great work being done across the world, very exciting. And certainly the science, the data science, the AI science is tremendously exciting. And the reason that you see great work that's been done really over the past several years, but not a lot of outcome data, is exactly what Jacques alluded to and spoke to beautifully. And that is implementation is challenging. It takes time. It's not trivial. And it's one of the reasons that AI for PI is so important. But yet there's even another step. And that is once we've built models that we know work and we've piloted them and validated them, made sure that they were safe and secure, and implemented them, there's yet another step, and that is sustaining them and making sure that they improve over time. And that kind of closed loop analytical process of iteratively improving outcomes and experiences for patients over time is really the substance of a learning health system. But if I use the definition of a learning health system as put out by the National Academy of Medicine many years ago, now a learning health system really kind of bakes in all of the things we've been talking about. Certainly updating science with the newest information that's available, informatics workflows, and technology like AI, but also incentives and culture. We know that implementing an AI model in one health system will be a very different experience than that which is implemented in another health system. And yet, these are the so-called soft science or soft elements of this process that are equally important in making sure that AI is safe, secure, and does what it's intended to do, doesn't drift, and improves over time. And so if we think about what we're aiming for, that is true value in care, which is quality of care, which can be defined a number of different ways at the micro and macro level or the patient or the health system level. But the quality aspect over cost, what we really want is value and driving towards value for our patients. And as you can see, while we're very excited about AI and all that AI can do, AI kind of fits into two verticals within learning health system science and infrastructure and data science and technology, but certainly engagement science, implementation science has already been described, system science and policy science, among other features, are really important in this churn of going from performance to data, data to knowledge, and knowledge to performance. And that is doing better with each and every day and making AI a part of that. So really, how do we get there? How do we scale learning health system access globally? Well, thankfully, again, standing on the shoulders of giants here, the Jeffrey Modell Foundation over the years has partnered with many of you in creating the Jeffrey Modell Foundation Clinical Network, or the JMCN, or the Jeffrey Modell Foundation Centers Network. And as you know, this is a global network of over 900 experts, 500 centers, over 300 cities, 89 countries, 6 continents, and is still growing. And linking this group together would certainly be a means by which we could share best practices, leave no one behind, no patient, any country behind in using this technology. And what we had seen really in thinking about how to take the next step with scaling learning health system access globally is developing a center that would be really focused on the implementation, the sustainment, the data science, and the AI science that is needed in this field. And so we're very grateful here at Virginia Tech that the Jeff Modell Foundation graciously established a Center for Informatics and Data Science that will be focused on scaling learning health system access globally. This formally opened and was dedicated here in Roanoke, Virginia, just a few months ago. And as you see, this will incorporate many of the multitude of really important stakeholders that are needed to both implement and sustain the pipeline for AI for patient finding over time. And there are yet even other challenges, and that is how do we share data with one another in a secure way? Certainly distributed models of learning, like optimizing models and then porting those models into health systems with an eye towards data security and sensitivity is certainly on the table. And this is something that the group across AI for PI is thinking about. And there's just so much going on in this community, and certainly with each iteration of the meeting, we learn more and more. So really, there are so many questions for discussions. Very excited to get to your questions and want to leave room for that. And we'll have at least 10 minutes or so for that. But some of the things we might want to talk about are the data integration pieces or some of the technical operability pieces. Certainly how this is deployed. Does it go to an expert clinician, or does a care coordination or population health team review this? How do we amalgamate data globally so that we can be better together? Certainly, the patient's voice is critically important here, and trust, and then scaling up, certainly ethics, fitting ourselves into the regulatory framework globally, but really that's different at each country level, and then a sustainability piece. So this is the last slide, then we'll get to the Q&A, and I'll turn the mic back over to Dr. Soler Palacin. A new era of data screening is really starting, and you've heard a good bit about that. Certainly, we're all focused on earlier diagnosis. The JMCN is critical. I want to just call out again, AI for PI 2027, and just thank the Jeffrey Modell Foundation and all of you for your time and attention. And with that, I think, Pere, take it over.
Thanks a lot, Nick and Jack, for these wonderful talks. Amazing. It's great because I think that I've heard you talking about that several times. I always learn a lot. So thank you very much for making that fantastic talks. So before going to the Q&A section, I have to say that there's a lot of guys working on that field. You already said so, but which is key, and I think that's the aim of the AIPI initiative, is that we need to work together. And we need to demonstrate that any initiative can be implemented in other countries with other health system, other EHR systems. So it's key that we need to work together. And these federated platforms that we can work with are key because, as you already said, that's the right way to share data without privacy issues. So that would be my request for you too. I know that you are working together a lot, but try to join all the others. And also, let's try to disseminate it to other countries and continents where this is not as easy as it seems to be in some Western Europe countries and the US, even though it's not that easy. But we need to make it happen worldwide, and I think that's quite aligned with what the Jeffrey Modell Foundation has tried to do since the very beginning. So that would be my willings for the future, for the near future. And I'm sure that in the next IP meeting, we'll be going into that. So now it's time for questions. Let's just go to the chat. There were some of them. I saw them here they are. Yes. So Linda Young, this is for Unique. How difficult is to get real metrics on the effectiveness of the PEPI program if blood tests or genetic tests, some that may be considered relatively basic, are harder to come by in rural labs?
Yeah, that's a terrific question. Thank you for that. As of this point, it's been a little over 2 years, and it took about a year to establish the program. And we actually don't have outcomes data. We have outcomes data from an educational initiative perspective, in that we can say there have been several hundred learner experiences and evaluations through the CME portion of the program. But we've worked really hard in canvassing the Appalachian region of the US and trying to connect to healthcare professionals around this region. And honestly, uptake has been a huge challenge. So we don't even yet have a we don't have a strong signal of how useful this program will be, but we're hopeful that we'll be able to move on to even metrics such as number of referrals for that elbow support, and number of ultimate, so into the PEPI program, and then number of referrals, say, from a rural clinician to an expert clinical immunologist. But then after that, for sure, we would want to know things like you're raising, which is really important, and that is the diagnostic rates, the molecular diagnostic rates, maybe outcomes for patients, and so forth. So you're tracking where we hope to go. And stay tuned. And please do reach out if you're interested in partnering. Would be very, very happy to collaborate.
Thanks, Nick. There's another question for you that comes from Turkey. It's Dr. Pamir Çelti. Sorry if I didn't say it right. Says something like on your web deployed LLM slide, the three high performers are Frontier 77B class models, while the smaller deployable ones sit at 42 to 60. But clinicians anywhere often means settings that cannot send patient data to a hosted model. Again, this is the problem. Have you tested whether retrieval grounding on the guidelines closes that gap for the small local models, or is it model scale doing that work?
Yeah, terrific question. We haven't tuned any models. These are models that were straight up out of the box. What was the native information that was embedded in their training information, which was really the internet. And these were the larger 70 billion parameter models, as you mentioned, but they weren't tuned at all. They were trained, but they were not fine tuned at all. So using RAG or some post-test training, I think would dramatically improve the performance of the models. And certainly that's also, I think, a community effort that could be undertaken. So this was again a proof of concept that encourages us that this could be a strategy that could be leveraged to scale knowledge to areas where maybe an expert clinical immunologist is just not available.
So this is for you two guys. Did you examine how COVID-19 related changes in healthcare use and clinical data affected the data sets and model performance, particularly in terms of temporal bias and data set shift? So,
Jacques,
Jacques,
please.
Yeah.
go
No,
ahead.
so yeah. I think that COVID-19, at least in the clinical experience, have shown that part of our clinical symptoms that were maybe not that frequent before, or the number of viral infection after, or other thing can have been shift in terms of post COVID-19. But in general, I think we still don't have um, let's say, no, there is some phenopackets or some things, but there is not a clear phenotype of each PID in the whole life of person into a health integrated health system. So it's hard to know if this has been changing or not that much before and after COVID. So my clinical side or a clinical experience would say part of it, the data, the direct data. I don't know if Nick has something on it, but I don't have a clear view of if there is a big change of pattern in PI, especially for diagnosis before and after COVID.
Yeah, it's a super interesting question, and certainly some of the IEIs that have been understood at the molecular level that were brought forth, like TLR4 for TLR7, for example, deficiency because of the stress test of the immune system that SARS-CoV-2 brought upon the human immune system. I mean that in and of itself is really fascinating. But I will make one comment, in our work, and that is when we ran data through the spirit analyzer and we looked at the high risk individuals, we binned them into those who may have primary immune disease or were very unlikely to have primary immune disease and we had RB approval to do this, looking at all of the other structured diagnostic codes in these individuals. And so some of those individuals, you won't be surprised, they had secondary immunodeficiency, or they had very likely secondary immunodeficiency. And then another big group, depending on the sample that we took across that 3-year arc of time, there was a signal of COVID. So there were patients there that had comorbidities related to COVID without a clear primary immune disease, but it does beg the question, did they have complications because they had an underlying primary immune disease that wasn't diagnosed? So really great question. It definitely does make the data nuanced and different, and the pandemic had impacts into the data science of this approach.
And
Thank
Nick,
you.
sorry, do you think because when we analyze our cohort locally before the pandemic and we run again the algorithm on the same population but 3 years later, so the pandemic has passed and the population had changed partially, of course, as every population changed, there was not big differences in terms of number in terms of gross number. So do you think there is, as they no, they were asking, there is a direct change on cohort if you have enough years of cohort? Do you really think? Because my feeling is that there is not a big change in terms of so if a model is let's say done pre-COVID, it should be working post-COVID also.
Yeah, I mean, it's a great question. I think that gets to what features are, embedded in the model and what features are heavily weighted in the model. And I think if there are features that are well represented by COVID illness, then there probably isn't going to be a substantial difference. But if there are gaps in features that are really relevant to the pathobiology that expresses IEI due to COVID, then there could be performance drift. So I think it does get to the point that repeat validation and tuning of models is needed over time because, honestly, it's hypothetical. We don't really know, but I would expect that there would be some change.
Thank you, guys. I think we have two last questions. I hope we have time for that. One comes from Manish. Manish says, brilliant work, Nick and Jacques. I have to say, Manish, thank you very much for your work on the field. I mean, I don't know if you were here at the beginning, but we made it happen in 2022, and we are here thanks to you. So thank you very much. So he's saying the sharing of EHR and genomes across institutions is turning into a real barrier in 2026, especially as health systems are perceiving the economic value in their databases. So can you share some ideas about how we can work together and overcome the desire to clutch data tightly?
Hi, Manish. Thank you for that question. So yeah, I think it's a bit what Nick commented before and what we have been commented during the webinar. I think that of course it's institution. It's a lot of work to have a really good database. The quality of the data is there is a lot of hours. Either if it's curated partially manually or totally. In general, a database quality is very important to do whatever we want to do with it, and each institution values it. But I think federated learning has its potential there because you don't have you don't give the database to another third party, but you can use it to collaborate. And I think the important thing is, as we have done things in this community in general, I think it's through collaboration and sharing and being really collaborative with each other. And I think the good model of that is the JMF and all the initiatives that they have.
So let's hear the US perspective from Nick, because probably it's not the same. Let's hear him.
Yeah, I mean, I think it's a great question, Manish. Thanks. And thanks for being here. And again, thanks for all your work. I mean, I think what's technically possible is so different from what's, possible from a regulatory or data privacy and security perspective and landscape. I mean, I think there is great work being done in architecting really an abstraction layer that makes the data information retainable without the patient identifiers. And I think that kind of work that is being done but hasn't been implemented here is ripe for rare diseases. And I think that could incorporate for sure structured and unstructured electronic health record data. Genomics is probably touchy. I can say, from my own personal experience, very anecdotal, but each health system that I've worked in has had their own nuances in terms of data security that you really had to navigate. And it is kind of one by one. You've seen one health system's, data security policy, and you kind of see one health system's data security policy. So there's a lot to navigate there, but I think there's hope on the horizon. I do think it's a soluble problem.
Okay, thank you. And now I think we have several more questions, but I think this is going to be the last one for the sake of time. And Roger, let me know if I can work with the others. But that comes from a patient. It's John Herstrom saying, I'm an II patient and a local advocate in Northern Nevada. Is it feasible to work with my local healthcare system or medical school to implement the Spirit Analyzer and extension or the PEPI or ECHO project?
Yes and yes,
That's
it
for you.
absolutely is. And could not thank you enough for that question and your future engagement. Please reach out. Yes.
So another good point from the webinar. Roger, can I take the last two ones, or should I adjourn the meeting here? Let me don't know. Okay, so I'll go on my own. So there was a very good one. So is it possible to and reasonable to adapt the questions and warning signs to address directly to a less educated urban and rural population? Yes, now I see you. Yes, thank you, Jessica. So I think that's a key point. That's a key question. So we need to make sure that we disseminate it to every single healthcare system. So what's your feeling on that?
Go ahead, Nick.
Okay. Yeah, sure. No, and I definitely want to hear from you, Jacques. I'll just comment and say that I think this point about health literacy is critical, and there's broad disparity, right? Some estimates suggest that 90% of the US adult population suffers from health disparities. So I can't comment on other countries, but in the US, it's a tremendously important problem. And so thinking about the warning signs, not as necessarily the guts of the spirit analyzer and the codes that underlie that, but as a heuristic or a rule of thumb for considering the diagnosis and evaluation of a patient with PI, I think there's tremendous opportunity. This is a fantastic question. Some of this work has been done, and even like discharge summary notes and passing those discharge summary notes from a hospitalization unrelated to PI to patients after they go through a LLM that allows them to be interpreted at, say, like a certain grade level, a certain comprehension level. So I think LLMs also help us with comprehension and driving that so it can be tailored to individual communities. But this is a terrific comment.
Any
Yes,
comment, Jack, from your side?
no, yeah, I think as Nick said, although I think in Europe it's a bit different in terms of accessibility to health and inequities, especially on let's say on the data or the published data that we have. We do have, of course, in Europe inequities. It's not the question, but I think it's the reality is a bit different. But yes, I think more than the warning signs by itself can be used in different ways. They can feed the spirit analyzer, they can feed a PitCap algorithm, they can feed any initiative that is been done like that. But they can also be a clipboard and a pencil, let's say, and you can adapt them to very different tools that you have. And if you have, for example, access to a big LLM model, big commercial LLM model that we all know, and you only have a paper describing the warning sign, then you can feed that paper to your LLM and use that as a tool also, which would be using AI to try to help diagnose a patient. So I think that here we have a chance, especially in low-income countries, to also disseminate the efforts that are done in different spaces and different countries. But we know that there is countries where there is no running water, but they have internet connection and cell phones, so they have access sometimes to a technology that can be used in the benefits of using those warning signs and adapt them to their reality. This is part of implementation. Implementation in science is to know what you have and how can you use what you have and how can you really implement it.
Thank you very much, guys. I think that at the very end, if we are able, with all the tools that you have been talking about, is create a kind of SOP for everyone to adapt that to each real daily life. So that's key, because it doesn't matter if it's in paper, if it works within a commercial LLM, or if you can use Spirit, Pepe, or whatever. So I'm sure that we'll get into it if we go there together. So sorry for the remaining questions. We're out of time, and I think that we need to adjourn the webinar here. Again, I want to thank you all for being here. Thank you very much, Nick and Jacques, for your wonderful talks, and obviously thanking the Jeffrey Model Foundation, Fred, who I know is there, Vanessa, and everyone for making that possible. Thanks a lot, and see you all very soon, and enjoy the summer.
Thanks, everyone.
Thank you.